The postpartum period is a time of many changes for women who've just given birth. And in the ER, we often have to think about postpartum preeclampsia, postpartum heart failure. But something that might slip under the radar is postpartum psychiatric issues. So today we want to discuss some of that with Dr. Mera Ackerman. She's an associate professor of psychiatry at NYU. Dr. Ackerman, thanks for being here.
Thanks for having me.
All right, let's get right into it. What should we be thinking about when we're talking to a postpartum patient?
So, with postpartum patients, in the first couple of weeks, baby blues is very, very common and not something that we would think of as requiring clinical intervention. But I think it's important to understand what that is and what it isn't. So,
Okay.
baby blues occurs in up to 80% of new mothers.
Wow.
And we think it is associated with hormonal changes at time of delivery, right? So women go from having stably high levels of estrogen and progesterone to them plummeting within the first 24 hours after delivery. And we think of this as like the hormone cliff, as you will. And so we think that, and of course, just the emotional experience of having a child, sleep deprivation that goes along with caring for a newborn can be an impetus, for baby blues. And baby blues is essentially a high emotional state where we can see uh, episodes, bouts of crying that kind of feel like they come out of nowhere, interspersed with moments of joy, uh, and that can feel overwhelming for sure. But it really comes and goes. It's not a persistent mood state and self resolves within the first 2 weeks postpartum. And so that really is different from postpartum depression, which can set in within the first couple of weeks postpartum, but we tend to clinically think about it as symptoms that present within the first year postpartum
Oh,
as
wow.
still having a postpartum depression signifier. Although if you look at the DSM-5 criteria, it is defined differently. So it's defined as symptoms of depression presenting in the third trimester or within the first month. But I think what I'd like to highlight as a clinician who's doing this work on the ground is we really think of the first year postpartum as being a time of vulnerability for postpartum depression. So, what does that look like? So, different from baby blues with postpartum depression, we see persistently low, sad mood or irritability. And often this is a very anxious depression. So, somewhat different than how we think of classic major depressive illness, which is more sad with neurovegetative symptoms like people who are sleeping more, not getting out of bed, low energy. That's actually much more rare in postpartum depression. We often see a strong anxious component and phenotype where there's a lot of sort of worrying, cognitive rumination, a sense of not doing things good enough, and difficulty kind of settling down to sleep, even though they're exhausted and needing sleep. Bear in mind, about 10 to 20% of women will experience a postpartum depression. So it is quite common. And the most common risk factor for postpartum depression is untreated depression during pregnancy.
Oh, okay. So it sounds like the difference between baby blues and postpartum depression, one is that the baby blues would end within 2 weeks generally, but a postpartum depression would extend the time frame out to as much as a year and possibly start in the third trimester. But also, you're saying the quality of it is a little different, that it's more of an anxious type of depression. It's more constant. It's not like waxing and waning.
No, that's right, exactly, and there's more of that cognitive element, right? The ruminations, the sense of there could be guilt associated, and that you really don't tend to see that with baby blues. And of course, if you see suicidal ideation, we've gone beyond baby blues, right? Even
Of course.
automatically, like
Yeah.
right, even if it's within those first days to weeks.
And so then,
And suicidal ideation is not uncommon actually in postpartum depression. It doesn't, most patients fortunately are not going to act on those thoughts, but having intermittent thoughts of not wanting to be alive or feel, particularly in the sense of feeling totally overwhelmed, can really come up.
now, is there some sort of validated, screening thing that we could look at to assess this?
I'm glad you asked. There is. So we use often a validated instrument called the Edinburgh Postnatal Depression Scale. It's called postnatal. It's out of the UK, but it actually is also validated in pregnancy, and it really is, I think, the best validated tool to use screen for postpartum mood and anxiety disorders because it takes into account these symptoms that we're talking about, like sleep and appetite changes, for example, and then weighs in other associated symptoms that are specific to postpartum depression, more of the cognitive, ruminative worry. The other thing I recommend doing is an MDQ, which is the mood disorder questionnaire. The good thing about both of these is they're freely available and they're pretty short. Neither of these things are diagnostic, but it does clue you in.
Okay. All right. So we've talked about baby blues. We've talked about postpartum depression. What else should we be thinking about?
So let's talk about postpartum psychosis, which, is a psychiatric emergency. So it's out of the things that we treat as psychiatrists is one of the most critical that we don't miss the diagnosis. And I think as emergency physicians also, you may be the ones to encounter patients with postpartum psychosis. And it's really important to know what you're seeing and know what the intervention is to manage it, because this is a really scary condition, but it also is very treatable. And we can really make a big intervention to help patients and their families if we get it right and we catch it. So postpartum psychosis generally presents within the first 4 to 6 weeks after delivery. And the symptoms essentially are delusional thinking, paranoia. So paranoid ideation can be in a variety of flavors, but often with postpartum psychosis, you'll see that delusions or paranoia revolve around partners, if there's a partner involved, or other family members, or around the baby. Commonly, not exclusively, but commonly. You can see hallucinations. You don't have to. And the other thing with postpartum psychosis is there are features that look like mania. Generally, these patients are pretty revved up. Like they're not sleeping as much. They feel very activated. They're behaving bizarrely. And this condition, unfortunately, does increase the risk for violence, for suicide, or self-harm behaviors, and of infanticide if not treated. So we think of this as an absolute psychiatric emergency. The rate of suicide in untreated postpartum psychosis is 4 to 11%. And the rate of infanticide is 4%.
Wow.
So this is a high morbidity, high mortality condition.
Right. That's something that we really need to identify. Now, maybe we could dive into the ways in which this would present a little differently than a normal patient with psychosis that we're seeing, day in and day out.
Absolutely. This is pretty rare in the sense that in the general population, the rate is like 1 to 2 per 1,000 live births. But in patients with bipolar disorder, it can be in as many as 1 in 4 patients with untreated bipolar illness can develop a postpartum psychosis. And so
Okay.
this is one of the main drivers for why it's so critical that we mood stabilize patients during pregnancy to prevent against the risk of postpartum psychosis. And
So a
so
patient with a
most
history
commonly,
of bipolar, that's someone we should be really
totally.
okay.
Yeah. So if you hear history of bipolar disorder, antennas should go up.
Mhm.
And part of the thing that can help clue us in is there a family history of bipolar disorder?
Okay, so maybe you could walk through what this postpartum psychosis patient would look like in the ER.
Sure. So when I can remember for myself when I was particularly in residency a few times where I encountered patients with postpartum psychosis working in the emergency room. And I think there are some things that are highlights of this particular condition that it's important to be aware of. So often these patients will be brought in by someone else, right? There's a lack of insight often and difficulty with reality testing. They can come in and look like someone that you've seen otherwise with psychosis, but something that's quite unusual is you can see that the symptoms wax and wane. Meaning, I examined the patient at time point A, held them for a few hours over the course of my shift, and I go back at time point B, patient seems better. Like she's talking to me in a more organized fashion,
Interesting.
not as preoccupied. It's kind of weird. Don't let yourself be falsely reassured. This is a really strange phenomenon of this condition that almost looks like a delirium, right? Like they're disorganized and not appearing well, and then it can appear well hours later. It's strange. And again, I don't even know that we have a great understanding of the phenomenology of this or why this happens, but it is what we see. And so multiple points of assessment. And if you see someone and you suspect postpartum psychosis again is on your differential, hold that patient for an extended period of time, right? Like 4 hours is not going to be long enough, or right, two exams where you see someone who was really unwell at time point A and looks good at time point B. Don't fall into the trap of discharging that
Oh,
patient.
interesting. Or the other way
Um,
around, if the family's concerned, but when you initially talk to them, they seem very coherent and logical, maybe you want to hold that patient and wait a couple hours and maybe something will pop up and be displayed on the next
exactly,
exam. Interesting. Yeah, because
exactly.
we don't normally, when a patient's psychotic that we're used to, they're psychotic 24/7 pretty much.
Exactly. So that's the part that I think as emergency room clinicians is one of the most critical features of this diagnosis, because I can tell you there have been a number of patients I've encountered over the years who were seen in a ER and discharged and then represented, fortunately represented because family remained concerned or things got worse. And that decision or time in between can really be so risky, right? Because family can feel like, well, we brought them to the hospital, they were assessed, and they were discharged, right? And
Right.
we know it's hard for people to get, especially psychotic patients, to the ER to begin with. And so I think that sense of have a really high threshold to even consider discharge in a patient where this is on your differential and err on the side of admission, because patients who have postpartum psychosis, for us, it's a admit, 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 admit. And that's a hard sell, right?
Okay, that's very insightful. So just to summarize, we sort of have baby blues, which is, important, but not necessarily an emergency. We have postpartum depression, which is sort of an urgent situation. And then we have postpartum psychosis, which is truly an emergency. Let's talk about how we're going to manage each of these three entities.
But I think it'll be unlikely that a patient with baby blues is going to present to the ER because, again, the symptoms are going to be up fleeting. And I think most of the time people are able to sort of recognize that. So I think if someone does come in and you really think that's the most likely diagnosis, reassurance is probably needed. Follow up is important because, again, someone can have baby blues and it can evolve, right?
Right.
Postpartum depression, again, varying degrees of severity. But if someone has come into the emergency room worried about postpartum depression, it's probably more in the severe end of the spectrum. And of course, you're going to want to assess for suicidality. Again, suicidal ideation is not uncommon in postpartum depression. So, really sussing out, is their intent? Is their plan? They may well be okay to follow up in the outpatient setting. But I think the patients that they're thinking more actively, they have some intent, they again are not able to move on their thinking to something else or not able to cite protective factors. We need to think about hospitalization.
Okay. And then I guess moving on to postpartum psychosis.
So with postpartum psychosis, if let's say you're not the one in the ER, send the patient to the ER for an evaluation. I say that like it's so easy. It's not so easy, right? If you can't convince the family to come into the ER, it really is a 911 situation. Um, and we meet a lot of resistance because, of course, someone with a new baby at home, the last place that anyone wants to be is in the emergency room. So once the patient's in the emergency room, of course, it's like immediate safety. Like, how do we manage current symptoms and behavior? So you all are familiar with how to manage that in the ER more broadly, but I think things that come into play probably are like benzodiazepines, um, antipsychotics. And sometimes, again, people get nervous to treat postpartum patients, especially if they're breastfeeding. That can come up. Most of these medications can actually be used quite safely in breastfeeding. And remind yourselves that the intervention is so critical that even if, I would focus on intervening, treating the symptoms more than worrying about breastfeeding and breast milk, like that in this kind of
Right.
situation.
So I know a lot of us, for an acutely psychotic patient that's a danger to themselves or others, we might consider Haldol and Ativan or Zyprexa and Versed or some combination. Is that something you would recommend in these patients as well?
Completely. totally reasonable.
Okay.
And you don't need to feel like, oh my gosh, just because the patient's postpartum, we can't use our usual toolbox. I think by and large, the medications that we tend to use for acute agitation, as you said, like Haldol, Ativan, um, olanzapine, most of the atypical antipsychotics that come in oral or even the IM formulations are generally thought to be reasonable choices. And then it's really about don't discharge the patient, right? And because of the waxing and waning picture with postpartum psychosis, uh, you're not out of the woods.
Okay. So it sounds like
Most
these
of these
patients really need to be admitted. Question I have is, with someone with waxing and waning features to their psychosis, they may very well display capacity um, during clearer times where they want to leave and the family wants them to leave. What do you do then?
a great question around capacity, but if you're considering postpartum psychosis is the reason that you're holding the patient, even if that they are in a moment seeming clear, I think you have enough clinical reason. If you can document a rationale, like this person presented with, right, disorganized thinking, paranoid. And again, if it's postpartum psychosis, that is reason enough for us, like if I'm the psychiatrist in the emergency room treating the patient, to hold the patient involuntary.
Okay, so we can treat to stabilize, but it's going to be a very high bar to discharge any of these patients.
Exactly. Right. And it pulls our heartstrings, right? It feels
Of
like, well, of
course.
course we don't want to separate mom from baby. Like that feels like hugely problematic. I think it's a really difficult moment for us as clinician. It puts us sort of in this double bind. But to remind ourselves, like going back to the data, even like the rates of infanticide and suicide are so high with this diagnosis that the risks of us discharging the patient outweigh the risks of holding them.
Tough sell, but it makes a lot of sense.
And that's sort of it. And I think part of the treatment intervention is separating mom from baby. If this is postpartum psychosis, we really, for a period of time, I'm not talking about for an extended period of time, or I've had this misinterpreted in the past where someone says, oh, are you saying remove baby from custody? No, not at all. I'm not saying that at all. I'm saying in the time that the person is in a psychotic state, we need a period to evaluate the mom and stabilize the mom to be with baby.
So that's really great for the acute management. That's really useful for us. It's sometimes useful to just know what the trajectory is going to be for these patients. So it sounds like for baby blues, that's reassurance, self resolving. But let's talk about postpartum depression and psychosis and look down the field, maybe 6 months, a year. What's going to be happening with these patients?
Sure. So the large majority of patients with postpartum depression will be able to be managed in the outpatient setting. Although occasionally you will have patients who require admission if they meet those thresholds. In postpartum psychosis, with admission, these patients really can improve and do very well. The reality is, if we treat and we intervene, we can really most of the time stabilize these patients and prevent untoward consequences, and they may never again have these symptoms. I would say on average, lengths of stay on inpatient psychiatry are usually about 7 to 10 days, sometimes can be longer. And generally, these patients are treated with antipsychotics, maybe benzodiazepines, and most of them will need a mood stabilizer. And particularly lithium is very, very helpful in the treatment of postpartum psychosis. Not something that, again, I would expect that you'd be starting in the emergency room. You could if you felt so inclined or if the patient was there for an extended period of time. And then most of them really reconstitute. The psychosis can truly be treated to remission.
Well, I'm just really glad we had this conversation because it's something that you've heard about, you see on the news, but it's not something that's top of mind. So I think it's really useful for us in the emergency department to just keep this somewhere in the back of our head because it sounds like with that acute intervention we could really make a big difference.
Absolutely. No, I think if you pick this up and you intervene, you have so much ability to do so much good to help patients and families. And if you miss it, it can really be a huge deal and lead to untoward consequences.
Well, Dr. Ackerman, thank you so much for taking the time. This has been really useful.
Thank you for having me.